Welcome to the DR Nol program. In tonight's episode, and due to requests from our viewers, we have invited Professor Denniss to talk to us about heart and cardiovascular disease. Professor Denniss is a professor of medicine, University of Western Sydney, and he's a cardiology in the Western Sydney Local Health District. He is the Director of Cardiology for both Blacktown and Mount Druitt hospitals, and he's also a specialist at Westmead Hospital. Professor Denniss is also responsible and in charge, and he performs examinations at the cardiac catheterization lab, the CAT lab at Blacktown Hospital, which we have set up some time ago. And we are lucky enough to have her with us to talk to us about one of the most important muscles in the body, the heart. Welcome, Professor Denniss, and thank you very much for accepting our invitation. And we'll be asking you some questions for our viewers to understand what the heart is.
Thank you, Dr. Nol. As a cardiologist, I am biased that the heart is the most important organ in the body. Of course, without the heart, there is no life. The heart beats 70 times a minute for about 80 years, so it has to be in good working order. It looks a simple pump from here, but in fact it is quite a complex organ. There are several important parts of the heart which, if they become disease, cause problems. As you can see on the outside of the heart, in the red, there are the coronary arteries shown here. They are the arteries that supply nutrition to the heart muscle. Another big blood vessel, the aorta, leaves the heart and supplies blood to the rest of the body. I shall open up the heart and show you that there is much more complexity than just what you see on the outside. Here you can see the heart has 4 chambers. There are 2 atria at the top and 2 ventricles at the bottom. There is a heart muscle as well, which is responsible for pumping and sending the blood around the body. And there are heart valves as well, which direct blood in one direction and try to stop the blood from going backwards in the wrong direction. Not visible here, because in real life at surgery, for example, it can't be seen at all, is the electrical system. The main pacemaker of the heart is situated about here, and the electrical wiring goes down through the centre of the heart, down to the bottom of the heart, and helps with coordination of contraction from first the top and then the bottom of the heart.
Thanks, Professor. That's very informative. And it was very interesting to watch you when you're doing the examination and how we can see the real heart pumping under fluoroscopy. And well, it's a good explanation, and lots of our patients or viewers go through these procedures, and it's good to know what's happening to them. To put it in simple terms, what do you mean when you say cardiovascular disease or vascular disease?
Right. The arteries shown here in the heart, the small ones, are coronary arteries, which might be 2 to 3 or sometimes a little bit bigger in diameter than that, 2 to 3 millimetres, much smaller than another blood vessel, the aorta, which may be 3 to 4 centimetres in diameter. But each of these are examples of blood vessels. This model here shows the inside of a blood vessel, and you can see a section here where there is no abnormality. However, as time goes on, and this time frame varies from person to person, there might be some irritation or some damage to the lining of this blood vessel, and little fatty streaks form. As time goes on, this converts into plaque, and as you can see, if I turn the end of the blood vessel towards you, you can see that the plaque can cause some obstruction to flow down through the blood vessel. So with cardiovascular disease, we have fatty deposits of variable extent in the blood vessels. The blood vessels with time become less elastic as well, and there are narrowings which can cause problems. They can cause problems in the heart arteries, the blood vessels to the brain, the blood vessels to other vital organs, and to the limbs, so that people might not be able to walk as well because they don't have a good blood supply. When a blood vessel starts out in its youthful, normal state, there isn't any muck there. There is simply a lining on the inside of the wall. As time goes on, fatty deposits, as I mentioned earlier, can form, and they're covered over by a thin fibrous cap. Most of the fat in here is cholesterol, and some of it is in crystalline form. As more cholesterol and fat deposits, the vessel gets pushed outwards a little bit more, and initially the piping in between is preserved in diameter, but as the disease gets worse, the piping gets more and more narrow, and there can be a restriction of flow to the heart, which can cause issues. If this cap that lines the fat ruptures, that will place the fat in direct contact with the blood in the blood vessel, and this can be very prone to promote clotting of that blood vessel. So you can convert a situation where you've had flow, albeit limited, into no flow because there's a clot there. Sometimes this clot can be dissipated quickly, and sometimes it stays. If it stays in an artery to the heart, then a heart attack can occur. If it is there temporarily and then goes away, then there might be a period of cardiac symptoms such as chest pain that come then go. This is a little bit less predictable than the more usual forms of heart symptoms, which are more predictable as the narrowing occurs slowly with time. The same problems in the blood vessels can occur in the vessels to the brain and can cause stroke and can cause issues elsewhere, such as in the legs, and cause circulatory problems there.
Professor, thank you very much for this elaborative description and explanation. I just want to ask a further question. Is cardiovascular disease always progressive?
No, it is not. It is not inevitable that vascular disease in the blood vessels will progress. Aggressive risk factor modification and treatment of high cholesterol with medications such as the statin class of drugs can actually stabilise this plaque and slow progression of disease. In some instances, it actually causes regression, particularly if the plaque is relatively soft and doesn't have much calcium in it. So, in answer to that question, no, it is not inevitably progressive.
So that means it can open up with treatment?
It can not only, in a minority of instances, open, it in the majority will stay either not getting any worse or getting any slowly worse. But there's another effect of the statin class of medications, and that is that it smooths out the plaque so that it's less unstable and less likely to rupture. So there's the added benefit of the statin class of drugs not only to lower cholesterol but make the plaque more stable.
So in those conditions, when it's getting better in treatment, would you see any role in further treatment through catheterization to clean up that area, or you just leave it alone?
Well, I would always, first of all, start with the simple risk factor modification. Now, there are a number of modifiable and a number of non-modifiable risk factors for vascular disease, and in particular vascular disease involving the heart. The non-modifiable risk factors are age. You can't do anything about that as you get older. Sex. Unfortunately, males are worse off than females. You can't do anything about your family history if someone in your family has a heart disease at age less than 60. And you can't do anything if you've already got established diabetes. There are, however, modifiable risk factors that you can do something about. Smoking, high blood pressure, high blood fat levels, low levels of physical exercise, and obesity. They are prime things that one can do about. One can modify those and stop the vascular disease from progressing as fast.
Thanks, Professor. We'll take a small break and we will be back with the Chief Editor of Heart, Lung and Circulation Journal after the break.